Bismillahir Rahman Rahim. Assalamu alaikum. Today we are having a guest lecture from one of our colleagues, Zohair Ahmed, who is basically assistant professor at the University of Illinois, Chicago. And his main interest is in the endobariatrics. This is a new field, I must say, and full thickness resections, as well as endoscopic sleeve gastrectomies, and all these things are possible now. He specializes in that, and he contacted through a combined friend. So we were saying that he's also having another lecture today with the undergraduate, how to get into the residency at US. For us, this is a new field and avenue because we are not doing it. The main reason is there are two reasons. One, the expertise, and second is as well as these equipments and these gadgets are quite expensive for us. For us, surgery is a little cheaper as compared to these gadgets. As you know, he has done his, he completed his schooling, medical schooling from the US, and then from University of Illinois, he did his internal medicine, and then fellowship in gastroenterology, and then he had 1 year dedicated training in advanced interventional endoscopy. So without further delay, Mr. Zohair Ahmed, please continue.
Just let me know if you're unable to hear me. Thank you again for allowing me to come here to give a talk. I want you guys to know that Shifa is certainly making its mark in the world. Over in Chicago, we've heard a lot about Shifa. A lot of graduates from Shifa have actually joined residency. A couple of them are my colleagues, so you guys have certainly made your mark. So today's topic, like Dr. Saleh said, is we're going to focus on advances in endoscopic management of obesity from past to future. So again, a brief overview of the talk. We're going to understand the pathogenesis, the health implications, and treatment of obesity and why it's so important, especially in the field of gastroenterology. So there's been recent scientific advances where we focus on the GI tract and gut-derived hormones, and we even look at the microbiome, so we even look at the feces and the stool content, and we've seen that these are key regulators of food intake and energy homeostasis. So obesity plays an important role, again, in the pathogenesis of common digestive disorders, such as GERD, such as esophageal adenocarcinoma. We know that obesity is a risk factor for colon cancer, and again, non-alcoholic fatty liver disease. This is probably our biggest player in this game. So the estimated cost in the United States of treating obesity and its directly attributable diseases in the US is $200 billion annually. This accounts for about 21% of our US health expenditures, and obesity has become a global health concern. So the United States, we have at least 40% of our adult population is obese, so this is very striking. When you look at obesity and its consequences, this slide sums it up really nicely, where they look at which cancers are associated with being overweight and obese. So esophageal adenocarcinoma, people who are overweight or obese are about twice as likely as normal weight people. So again, in the United States, I'm not sure about here in Pakistan, but you have someone who's Caucasian, who's male, who's obese, they develop GERD, and then they develop some dysplasia, and then they go on to develop adenocarcinoma. For gastric cardiac cancer, you're twice as likely if you're obese or overweight. For liver cancer, again, this is mainly due to the obese population that have fatty liver in the United States. They go on to develop HCC, and thus they're twice as likely as normal weight people. Colorectal cancer, so again, slightly about 30% more likely to develop colorectal cancer. For pancreatic cancer, we found 1.5 times the risk. For renal cancer, it's twice as likely. And the most striking is endometrial cancer, where it's 2 to about 4 times as likely. And we have a gyn-onc attending with us here today, so hopefully they can attest to that. So the prevalence of obesity varies considerably in different ethnic groups. The most recent data from the CDC found obesity rates to be highest among non-Hispanic blacks. 47.8% were affected with obesity, and Hispanics were 42%. Currently, about 32% of our Caucasian population, they suffer from obesity, and roughly 10% of Asians within the United States have obesity. So again, it's very, very important to recognize the morbidity and mortality that goes along with obesity and how it varies amongst different ethnic groups. For example, in 2003, we found a U-shaped curve where we found there was excess mortality at both low and high BMIs. For us, a normal BMI in the United States is 18.5 to 24.9, and we consider someone overweight above the BMI of 25. And that's where we see increased years of life loss due to obesity. But in contrast, if you look at the African American black population, we find that they didn't reach these circumstances until their BMI was closer to 32 to 33. And in black women specifically, they had a higher resistance, so they didn't see any of the unwanted effects until their BMI was 37 to 38. But more interestingly than that, for something that applies to Asia, is we're starting to see a lot of metabolic complications of obesity in a lower BMI. So we're not as resistant. So the most resistant is an African American female, where for BMI reaches up to 37, 38, that's where you see issues. But in Asians, you start seeing these issues once their BMIs are between 23 to 24. So again, at any BMI, abnormal high visceral body fat, this represents an additive risk for obesity-related complications. And thus, most commonly over there, we measure your waist circumference, as this remains the most simplest and common method for us to assess intra-abdominal fat. Abdominal adiposity or obesity for us occurs at a waist circumference of about 40 inches, which is 102 centimeters, in men, and 88 centimeters or 35 inches for women. The pathogenesis of obesity, going a little bit into the pathophysiology, so this has a genetic, an environmental, and a behavioral component. Based on heritability studies, we can see that genetics are thought to account for up to 70% of a person's weight, but then you have this interplay of your genetic milieu and the environment, and this is not completely understood, and this is why we're doing a lot of research in microbiome and things like that. The primary satiety signals from the gut, these include cholecystokinin, PYY, and PP, and GLP-1. So other important satiety signals listed here are amylin, and this is co-secreted with insulin from the pancreas, and slow is GIP. This was previously known as gastric inhibitory peptide, which is released from the K cell in the proximal small bowel. So in the fasting state, your oxyntic cells in the fundus of the stomach, they produce high levels of ghrelin, which is a potent stimulator of hunger. So once your food is ingested, the taste receptors in your mouth, they determine how palatable is this food, and they secrete hormones, as well as neurochemicals that are transmitted into your central nervous system. Following ingestion and mixing with your salivary enzymes, the food is transferred from the oral cavity down to the stomach, where its digestion continues. In the stomach, the food is mechanically broken down into smaller particles, and gastric distension and presence of intraluminal nutrients result in decline in ghrelin levels. So now that we have a basic understanding of the pathophysiology of obesity, let's go ahead and look at this slide. So this is what we're doing, and this is what we're talking about, right? So look at this slide as you're looking at the left side and the right side, okay? The left side, where it says gastric interventions, these are more restrictive effect on your body. So the first thing that we do commonly is balloons, right? Over here you see the stomach, and this is the balloon. There were two types of balloons on the market. One was the Orbera balloon, and the second one was the Reshape Duo. The Reshape Duo is no longer there, so all we have is a single balloon. The next one we have is a transpyloric shuttle. In here, this pretty much delays gastric emptying, and it works at the pylorus. The other common procedure we're doing is called endoscopic sleeve gastroplasty. So if you see here, This is in a surgical sleeve gastrectomy along the dotted line. Everything to the right of that is removed, and you only have about 25% left, which is what's shown here, which is what we do endoscopically. These other modalities aren't used as frequently. This is another one. Again, all you're doing is you're restricting the amount of free space within the stomach. This is called the Aspire Assist. This is a gastric aspiration device. It's pretty much inserted just like you put in a PEG tube. And after the patient eats, they stand in front of the toilet and they open the valve in front and they empty their stomach. The right-sided column that you see, these are all malabsorptive type features. So you may be example, classic bariatric surgeries include Roux-en-Y gastric bypass as well as a duodenal switch. So what we do is we insert liners that start all the way from the esophagus and they go all the way down to the jejunum. These liners are malabsorptive. They don't allow any nutrients to be absorbed, and these lead to the most of weight loss. Another emerging technique that's seen on the bottom right here is resurfacing, where they go in and with RFA ablation, we ablate the mucosa there and prevent it from absorbing any nutrients that you eat. But again, this leads to a lot of nutritional issues, and this is still an emerging topic. So endoscopic bariatric therapies, we spoke about why they're needed and so why they're important. So there was a survey done in America where we evaluated 40% of the population that was obese, and we asked them, are you willing to get a surgical intervention, whether that's a surgical sleeve gastrectomy, whether that's a Roux-en-Y gastric bypass. 99% of these patients said they are not willing to undergo any type of surgical therapy because they feel that it's invasive. So we found that there was a huge market out there where we needed to capture these patients. And thus, endoscopic bariatric therapies are more appealing to these patients because they're less invasive treatments. You have significantly reduced complications in endoscopic bariatric therapy. Some studies show that they have had 0% of complications. And there's decreased hospital stay. So oftentimes when we do endoscopic bariatric therapies, it takes us about 45 minutes to an hour to do the case, and these patients go home the same day. The patient population that you can also target are those that are too sick to undergo an invasive bariatric surgery. So we very commonly deal with patients that have advanced liver disease, whether it's stage 3 or stage 4, and we're oftentimes asked by our surgical colleagues to calculate their surgical risk. And we do this by calculating a Child-Pugh score. So some patients that have an elevated Child-Pugh score, they're not able to undergo invasive surgical procedures, and thus endoscopic bariatric therapies we do in these patients. Before we choose what therapy we're going to do, we always assess if these patients have significant portal hypertension from their advanced liver disease, because as you'll see, when we do the endoscopic sleeve gastroplasty, this is a full thickness suture technique that we do endoscopically. Now, if a patient has portal hypertension, has gastric varices, you obviously don't want to be suturing through that. So in those patients, we found balloons to be helpful. Again, some patients that don't qualify for bariatric surgery, this is a good option for them. So in America, if your BMI is 35 and you have a comorbidity, you qualify for bariatric surgery. If your BMI is 40, even if you have no comorbidities, you qualify. So oftentimes we have patients that see our surgical colleagues who have a BMI of 33, and they're pretty much left with the decision, okay, do I go home and gain 20 more pounds so my BMI is above 35? Or do I take a endoscopic approach? And these are a lot of the patients that we get as well. And in some patients, we do endoscopic bariatric procedures, so we can use it as a bridge for them to eventually get bariatric surgery. The current endoscopic bariatric modalities of highest interest or significance, at least to me, which I do, is the endoscopic sleeve gastroplasty, placement of an endoscopic balloon, and we're also doing a lot of transoral outlet reduction. Transoral outlet reduction means patients who've undergone a Roux-en-Y gastric bypass, their gastrojejunal anastomosis, which we call the gastric outlet, that over time has increased in diameter. Normally, the diameter of that outlet should be 6 to 10 millimeters. In patients that commonly regain weight, their diameter is up to 50 millimeters. So we can endoscopically suture the size of that diameter back down to 6 to 10 millimeters. This is a schematic here of the endoscopic sleeve gastroplasty. Again, this is showing you what's done surgically. And this is what we do endoscopically. We put in these full thickness sutures. Over here, if you take a slice here and you look at it in a cross-sectional dimension, this up here, the top circle you see, this is what you're left with. These are excluded with full thickness sutures. So we're going to see if this works. So again, this is our scope. We have a suturing device attached to the end of it, and we're now going inside. So what we first do is we take our APC device and we demarcate the anterior wall of the stomach, and we mark our posterior wall of the stomach. And then after we do that, we attach our suturing device and we put in full thickness sutures. We go along the anterior wall, that's the greater curve in the middle, and the bottom is the posterior wall. So we keep doing this in sets of 2, and then we come back down to the posterior wall, and then we start where we started, and we release our cinch. And we do this, and these are full thickness. And we move along, and we move up towards the fundus. And so afterwards, if you see, that's how big the stomach was, and even that bottom portion is excluded. What you're left with is the 25%. And then we put in these reinforcement sutures to ensure that nothing opens up if the patient eats a lot. So endoscopic sleeve gastroplasty, what does the data show and how much weight is lost, right? That's important. So one of the largest studies was done by Lee et al., where they looked at over 1,500 patients. And after ESG, the total body weight loss was 8.78% at 1 month, 16% at 12 months. In addition, what we also calculate, which is a good measure, is we look at excess weight loss. So we calculate what your normal BMI is, and then anything you have above that constitutes as excess weight loss. So we were at 31.1% at 1 month, and you've lost 59% of your excess weight loss at 12 months. So both ESG and the laparoscopic surgical approach, these are both restrictive procedures. In both of these, 2/3 or up to 75% is surgically removed, and this will decrease your appetite and increase your satiety level. Studies comparing the endoscopic approach to the surgical approach show that in endoscopic surgical sleeve gastrectomy, we had decreased length of stay, there's decreased morbidity, there's decreased adverse events, and there's decrease in GERD. So it's very common practice in America, before any patient undergoes a bariatric surgery, they get referred to GI and we do an EGD. This is done just because we want to make sure that there's no large malignancy within the stomach, there's no large ulcers, but also more importantly, we look at if the patient has significant esophagitis or GERD, reflux disease. Because if the patient has significant or advanced reflux disease, we let our surgical colleagues know that this patient is not going to do well with the laparoscopic sleeve, because in laparoscopic sleeve you have increased rates of GERD. Instead, we recommend to them that the patient get a Roux-en-Y gastric bypass. In a Roux-en-Y gastric bypass, you have decreased incidence of GERD, or they could get an endoscopic sleeve where you have decreased incidence of GERD. In patients who did have a BMI that was greater than 40, they achieved greater weight loss in the surgical approach than the endoscopic approach. This is the endoscopic balloon therapy. It's made of silicone, which we commonly use over there for breast implants. It's the same material. It's pretty long-standing. Currently, we're only putting that in for 6 months, but in Asia and other places, they're leaving for more than 12 months. So there's a strong push. We recently, our FDA approved it for emergency approval for patients with fatty liver disease as a modality for weight loss. So I'll show you that procedure. This is a very simple procedure. It's as simple as putting in an NG tube under endoscopic guidance. So we go in with a deflated balloon and we fill it with about 400 to 600 cc's of saline, and that's it. We come out. So it's that easy. Of course, before deploying the balloon, we make sure there's no large ulcers, no large gastric malignancy, which would be a contraindication. And then after 6 to 12 months, we go in, we put a 19-gauge needle in there, we suction and aspirate all of the fluid out of it, and then we put a device that has a 3-prong thing in it, we capture it, and we remove it. Okay, so what do the studies show about intragastric balloons? So there was a very large study which looked at 2,500 patients, and they reported there was a reduction in BMI by 4.9 and excess weight loss of 33.9% in a 6-month period. They looked at other comorbidities, so hypertension, type 2 diabetes, osteoarthritis, and hyperlipidemia. These nearly resolved in 44% of patients. The other therapy that I told you we commonly do is a transoral outlet reduction. So if you look over here, if you look along this outside circular line, that's how big this person's outlet got after surgery. So when you do a Roux-en-Y gastric bypass, you create a very small gastric pouch. The gastric pouch is very small. If you overeat, there's not much room for the stomach to accommodate. So everything downstream starts dilating. So over here, if you look at the gastrojejunal anastomosis, this dilates up to 40 to 50 millimeters. So what we do is we can go in and endoscopically put in full thickness sutures. To do this surgically, it's a nightmare. So over here, as many of 50% of patients who underwent gastric bypass, they regain up to 39% of their maximum weight loss in surgery. So thus, there's a lot of demand for this in America. Traditionally, the dilated gastrojejunal anastomosis, which is this connection over here, from the pouch to this limb of jejunum, this was treated with a surgical approach, but this is technically difficult and has a complication rate of up to 15% when done surgically. So thus, endoscopic suturing of this has become very common and prevalent in America. We did some preliminary studies and some data from our in-house experience. We compared it with other studies as well. And major complications were about 3 out of 280. None of them resulted in mortality. We deemed an increased risk of bleeding and severe bleeding that was seen endoscopically as a major complication, but we treated all of these, and these patients did fine. So thus far, ESG is very promising. ESG is endoscopic sleeve gastroplasty, and this has limited complications. So the success of any endoscopic bariatric program, it's very, very important that this is a team approach. The amount of value and respect we give even to our nursing staff within our unit, the amount of appreciation we show to our medical assistants. For my team, we have a bariatrician who did her internal medicine residency, and then she went on to do a specialty in weight loss and nutrition. So we have one physician, and then we have a dietitian who meets with the patient, and we have a bariatric psychologist. All of these patients have to meet with our whole team, and we see is there an underlying eating disorder, is there an anxiety, is there an overeating problem, is there a binge eating problem. So we meet weekly, and we discuss these patients before we move forward. We follow up with our patients very, very regularly, and no matter what we do, if the patient does not change their diet or their lifestyle afterwards, it's very, very likely that they will regain a lot, if not most of their weight. And that's the end of my talk. If anyone has questions, please. So we know patients that have undergone diet and lifestyle modification in addition to medical therapy. The chances of them sustaining weight loss from just medical management without any sort of endoscopic or surgical management is inferior compared to endoscopic therapy. Now, your question of how do you decide what you're going to do when you have a patient in front of you? So a lot of times in America, since this is an elective procedure, the patient guides what they want. And sometimes they'll ask you your opinion, but their opinion's more or less made up. So you tell them, there's 2 options that we can do endoscopically. Some patients that I see that have a BMI of 50, I'll tell them that, you should get a surgical approach because you're going to have more weight loss by getting surgery.
But again, 99% of the overweight or obese population does not want surgery for whatever reason, even though we do everything minimally invasive, everything's done at our institution laparoscopic and robotically now, all of our bypasses and everything. But these patients still don't want to get it. So a lot of times you're sitting there trying to convince the patient that no, don't do it endoscopically, do it surgically. But these patients, in their mind, to them, if they don't have any surgical incision on the outside and everything's done just from the inside transorally, they're often going for that. So getting back to your question, it's very patient-directed, and the patient often picks what they want. But for me, in my mind, what I say is if your BMI is between 27 and 30, I would recommend that you take medical management and take medications. If your BMI is above 30, then I'll probably recommend you get a endoscopic balloon or endoscopic sleeve gastroplasty. And if your BMI is above 40, then I'll recommend to you that you get surgery.
That's irrespective of the comorbidities.
Yeah, if I see that it's a fairly young person who's 35 or 40 who's got diabetes, hypertension, hyperlipidemia, this and that, then I may be a bit more aggressive with them. And some of these patients are starting to develop fatty liver disease. And if they've already undergone a liver biopsy and they're already stage 2 or stage 3, then we'll be a lot more aggressive with them as well to prevent them from getting cirrhosis. The most common indication for liver transplant in the United States has always been hepatitis and alcohol. Now, obesity and fatty liver disease and NASH has been the #1 cause. I mean, you may think I'm joking, but geographically, where you live in the United States, there's very concentrated pockets of obese patients. So, as you know, you're from the U.S. as well. So the Midwest, you go down south towards Louisiana, New Orleans, all these places. It's hard, honestly, for some of my patients to fit through that door. They have to come in sideways. And I mean, this is a real issue for us over there. No, we haven't had that. I've seen some of those studies, but that hasn't really taken off in America as much because I think Botox is a more of a temporary solution too. Oftentimes we give Botox for some of our esophageal disorders, but this is shortly lived. And so even the balloon is fairly temporary, right? 6 to 12 months, but I think Botox would be even less. So, when I was doing the balloons, I was doing it under what we call MAC, monitored anesthesia care, where we have an anesthesiologist in the room, they just give propofol. But it's recommended even for the balloon, you do it under general anesthesia. Initially, what we were doing is before you put in the balloon, you do an EGD. Okay, now you've determined I'm going to put in the balloon, everything looks fine. So when you put in the balloon, it's kind of like an NG tube that you're passing, and most of the time you're going to pass it down the esophagus into the stomach. But if you pass that balloon into the trachea, and then if you try to pull back, the way the balloon dislodges from the long cord is you just pull back. So if you've now put in the balloon towards the trachea and you pull back, then you've permanently more or less kind of left it there, and then it becomes a nightmare. So if you just protect the airway, if they have a endotracheal tube there, it's recommended. We've done some cases where we've done under monitored anesthesia care, but all endoscopic sleeve gastroplasties and patients who undergo transoral outlet reduction or revision of their surgical procedures, those are done general anesthesia. So in America, as you know, our healthcare costs is exuberant and oftentimes not justified. For a laparoscopic sleeve gastrectomy, you charge the patient's insurance almost up to $25,000 to $30,000. This includes the surgery. This includes them staying in the hospital for 1 to 2 days. Now, I mean, the physician doesn't get the $30,000, right? But that's what you bill the insurance. For our endoscopic sleeve procedures, we do it for under $10,000. So it's a significant reduction in healthcare costs for these patients. For our balloons, we charge about $7,000. But the important thing to realize is it's not just $7,000 for them just getting the balloon. So this includes visits with me, visits with the dietitian, visits with the bariatric psychologist, visits with the whole team, and covering any sort of complications that may arise afterwards as well. Yeah, I think that's an important point that you made, and again, you also made the point that, you know, despite what the patient wants when you look at monetarily, that's interesting because over there it's more expensive because these patients stay in the hospital for at least 1 to 2 days. So over there, even staying in the hospital is a large cost. But I think if you start introducing endoscopic sleeve gastroplasty in this institution and in this area, I think there will be significant demand because we were very, very surprised when we saw that only 1% of patients were getting bariatric surgery. You know, we were extremely surprised by that. And the reason why we had to look into it is because obesity is such a huge problem in the US. We were wondering and asking ourselves, why are we losing in obesity? What's going on? Why are these patients not doing what they're doing? And then we asked and we found the answer, and it was 99% of them didn't want to get the surgery. So I'm not sure what people's hesitancy is in Pakistan in terms of getting a surgery versus getting something endoscopic, but at least in America, the endoscopic route is preferred by patients. So they're proline, 2O-proline sutures. It's not an auto suture. It's a Orbera. It's called a Apollo overstitch device, and so what it has is it's like an anchoring system too. So we put something out and we put in the anchor and we turn it, and then we pull that piece of gastric mucosa within the biting apparatus. And then once we're ready to take our full thickness suture, there's a handle we push. We push the handle and that does the bite. And then we have a thing coming, we use a 2T scope and we pull it out, the device, and that suture comes through. And then we do the same thing. It's quite a tedious process to learn it. It is a bit challenging, but I think if you're a good endoscopist, you should have no problem learning and picking it up. Yeah, so that's a great question. I would say before I answer it, number one is always have a great relationship with your surgical colleagues. Our program would not be where it is today if it wasn't for a close relationship with our bariatric surgeons. Initially, when we were doing these, we would give our bariatric surgeons a heads up, hey, I'm about to start a case, just FYI, if anything goes wrong, if you don't mind being on backup. Knock on wood, thankfully, personally, for me and my colleagues in the US that do endoscopic sleeve gastroplasties, these are very safe procedures. We have not, the worst I've had was, I don't know if the patient had a Dulafoy or what they had in the area, but these patients sometimes can have significant bleeding. But if you just stop and you coagulate and you clip, these patients all end up doing fine. So there really hasn't been, and the gastric mucosa is, I think, one of the thickest tissues in the human body. It's very thick, almost like leather. It's very hard for you to do anything. And even if you it's hard to perforate even with your suturing device because it's a very thin needle driver that goes through it. So we haven't had too many complications. I haven't read of too much data out there that has shown that there were quite a few number of patients that required surgery after. After you get a endoscopic sleeve gastroplasty, it does become difficult for you to get a Roux-en-Y gastric bypass. Now, some advanced bariatric surgeons have been able to do that because they still have, the stomach there, it's 25%. They just take the upper third of that, they create that as their pouch, and then they attach it to their limb, and they still do it. But it does become technically more challenging for the surgeon to do a gastric bypass after the patient has an endoscopic sleeve. There's studies that are looking into why that's the case. No one's come up with a exact reason why that's happening. So I'm not sure why there is, but there clearly is. As to why, in terms of pathophysiology, it's not too obvious. Because, conceptually, when you think about it, in a laparoscopic sleeve, you're removing 2/3 to 3/4 of the stomach, up to 75%. So you have less acid-making capability. And so when you have less acid-making capability, you'd expect less amounts of reflux. When we do a endoscopic sleeve, we're not surgically removing anything. That part of the gastric mucosa is still there. So conceptually, it doesn't make sense to me. You would think the reverse would be true, but it's not. And using that notion, Roux-en-Y gastric bypass patients, we feel they have less reflux. A lot of that is because you've excluded 80% of the stomach and you just have a small pouch. And so they have less ability to make acid, thus less acid will go up. So it doesn't make much sense, I agree with you, why an endoscopic has a lower incidence than laparoscopic. That's something that they're still looking into. Yeah, so that did take off for a little bit in America, but the studies haven't been too fruitful afterwards, so that's no longer in favor in America, yeah. So the endoscopic sleeve gastroplasty is more of a permanent solution. The intragastric balloon is something to help patients get the initial kick that they need. If someone says, I just want to lose 15 to 20 pounds, and then after that I'll take it from there, I want something that's completely reversible. But when you look at studies, the endoscopic sleeve gastroplasty leads to more sustained weight loss than the balloon does. The largest study here, they showed that you had excess weight loss of up to 33% at a 6-month period of your excess weight. So that's the weight above your ideal BMI. Yeah, the studies are mixed, but a lot of us that are doing advanced endoscopy and EUS, we're all putting in hydrogen peroxide. Yeah. Yeah, we put it in 3%. I think it's 3% hydrogen peroxide, half saline or half water. We dilute it down, and then we put it in. So, and it works like magic. And we tell these patients, actually, interestingly, we tell them to drink 3 cans of Coke a day, because we want the soda to go through the stent into this necrotic debris. Because what we did was we used to pull out chunks of this necrotic debris. We would put it on the table, and then you ask your nurse, bring me some Coke. They bring you a Coke, and you pour some Coke on there. And if you see how it liquefies it really fast, now we tell these patients, drink 3 cans of Coke a day. And we tell them, stop your PPI, because we want the gastric acid to go through that cavity and work within there. So we tell them no PPI and drink 3 cans of Coke every day. Yeah, so, you know, it's not like obesity is a problem there, but.
No, it's not, but we have got this NOFO, which is a non-obese fatty liver disease.
Yeah, yeah.
And we are basically sarcopenia. The main issue is sarcopenia. It's not like excess fat.
Yeah, and that's very hard. You know, what do you do in that situation?